This is a ureter. It's a picture that taken by Rachel Sussman, who has produced a book of the oldest things on the Earth. And the ureter is 3,000 years old, and I am, I guess it's a symbol of what we like to think in geriatrics, which is the older the better. And part of what I'm learning as I start to take care of people with HIV is I've got to try to reconfigure what I understand old to be. And just one acknowledgement that I will eventually get some grant support from Gilead. So geriatric primary care has four fundamental components, most of which I think are very, very familiar to those who are caring for those with HIV. I think where we add something is the comprehensive assessment, and I wanted to talk a lot about what that might bring to an HIV clinic. We have a lot in common. Our patients have medical and psychosocial needs, and we work in teams. And I've listed my colleagues and collaborators who've asked me to think a lot and helped us shape an HIV and aging program at the Center for Special Studies here at Weill Cornell. What I'm going to do today is begin with comorbidity and then shift the focus generally to geriatric care and end by asking us to think a bit about how we're going to integrate the two systems. So you've seen this before, but I think it's where geriatric care begins, and I'd like to emphasize it again. We have to account for multimorbidity. In the 50 and older, you have more people with comorbidities and more people with multiple morbidities, and that results in a cost of care over the age of 60 that exceeds the cost of HIV care. How are we going to help with the comorbidities? Well, my experience has been that in seeing patients, they have cardiologists. The comorbidities in general are recognized. What we can do and what we have done is help perhaps prioritize which ones need the most attention. We're looking at which comorbidities perhaps haven't gotten as much attention as they might, and I'm finding that I'm calling attention to perhaps the less frequently addressed comorbidities like bone health, COPD, and cognitive impairment. And I use the term address polypharmacy because I haven't figured out how to fix it. It's rare that we can tell someone to stop 5 different medications. It's usually a bit of nibbling at the edges. But caring for those aging with HIV, as you're hearing over and over and over again today, is more than managing multimorbidity. We obviously start again with assessment and prevention, smoking cessation, but geriatricians bring the other things. We want to address the functional and cognitive impairment. We want to assist with the relief of psychosocial burdens, and we want to help ascertain advanced directives and goals of care. And sometimes our mere presence reminds people that they have to do this. So I bring up 2 aspects of this. One, on the left is a article this month from the New York Times, not focusing specifically on HIV, but recognizing that loneliness is a phenomenon, especially people who are older, and that loneliness has medical and health implications. On the right is a reminder that often functional impairment and other problems begin with a comorbidity, in this case osteoarthritis. One of the things we have to understand is, one, what are the functional consequences of a disease, but also what are the what's in the environment, what can be brought to bear to assist someone who has the functional limitations. If you're of my vintage, you remember the WHO classification of handicap as this intersection between the outside world and the individual's impairment. The vocabulary changes, but one of our responsibilities is to look not just at what the function is, but how that function impacts the individual's ability to get on in the world, and what we can bring to bear to lessen that burden. So I begin with the HIV, the UCSF Silver Project, which identifies a lot of these things. On the left, I've broken down some of the data by the 50 to 59 group and then the 60+ group, in areas where there was a significant difference between the two groups, so that those who were over 60 and over were far more likely to have a balance problem and slow gait speed, far more likely to have good med adherence, and far less likely to have excellent or very good health. And I bring that up because, especially as a geriatrician, because how we help those who are entering, say, the 50 to 60 age group is going to be very different from how we help those who are already impaired. One of our responsibilities is figuring out what kind of advice can we give? How can we help people prepare, as opposed to how do we help people cope? And any geriatric program, I think, has to address both of those things. I think these are two different sets of requirements. The second is on the right are just some of the other things that they've identified, and again, none of this should come as any surprise to this audience, except again that they were looking at these questions: falling, ADL dependence, cognitive impairment, and loneliness, depression, and again, the same data that comes up over and over again. About half did not have social supports. All right, let's try again. There we go. So I've been playing around with trying to figure out where I, as a geriatrician, fit in the grand scheme of what patients need, and it's pretty low and off in the corner there. The comorbidity and aging and so on, I think, reflect one aspect of care. We can't talk to patients without bringing in the rest of both the psychosocial needs, but also what the educational needs are. And in some cases, patients teach me. In other cases, I can work with them. I've been playing with this diagram each time I talk with someone or learn a little bit more. One of the things that our patients have told us in focus groups is the importance of purpose. We have found that they want to set up buddy groups, but they want to set up buddy groups so that they can mentor younger people and teach them about what it is to live with this disease. So it took me a while to learn about stigma and the loneliness and so on, but every time I think I understand something, my patients are telling me something else, and recognizing that purpose is a very, very important part of their lives, and figuring out how to help them achieve that has been something that we're working very hard to do. So we've started a program for people aging with HIV. It began with geriatric consultation because that's the fastest way to get something started. I just find me a space and let me see people. And I will not belabor the reimbursement and billing issues. I can talk to some of you who have some practical questions about how to do that. But I saw patients and see patients on site, and I have another colleague who does. We also will see people on the inpatient side. We did a needs assessment for the staff and for the patients, and we've tried to educate staff at all levels. We have recognized that, and I'll get to this again at the end, that the social workers, for example, are extraordinarily sophisticated about the HIV services network, but knew very little about the aging services network, and figuring out how to get them comfortable with accessing services for people who are aging into the aging services network is something we've addressed but need to continue to work on. we are collaborating with community organizations, and we've gotten some foundation support. The Samuels Foundation gave us some money to set up a program. They are interested in funding aging-related programs, and we found that they were perhaps more receptive to this than some of the HIV foundations. And it's one of the things that you can think about is if you've gone to the Weill a lot with HIV foundations, they may not be ready for this. Aging-related foundations, I think, are. So I wanted to talk a little bit about what I do. For those of you who are clinicians and work with EPIC, you may recognize this. What we tried to do was a comprehensive geriatric assessment in an hour, which is not possible, but which I've tried to squish into something as comprehensive as I can. And we were able to get the folks who program behind the scenes for us to embed this in the chart. So we all share an electronic record. I'm able to enter this information as I go along and as I talk to patients. That then does two things. One is it prints out into my note, but there's also a place to find it in the chart separately. And many of these things I think are very familiar to you. I'm looking at frailty and depression and anxiety and strength, and I do a MOCA for cognitive assessment. I ask some general quality of life issues. I ask about pain. The other thing that I ask, and I start the conversation out, is just asking people what their goals are, what's important to them. That may take the assessment and the exam in a very different direction than I thought it would, but it opens up a conversation that is more robust than just running through the assessment. And there's a flow sheet function so that this is a made-up patient, but if over several years I wanted to do this annually, we can make a comparison. This is all through the record. I just wanted to give you a little bit of very, very qualitative data, and this is just what are the things people talk about? What do I find on that initial assessment? And I want to bring up several points. One is that, yes, comorbidity does come up, although, again, I'm dealing with very expert clinicians, and there's not too much that I find. Sometimes it's encouraging someone to follow through with something. Sometimes I do elicit a problem that I can then talk to the attending about. But there's a variety of other things, and cognition comes up very, very often, as does finding something in the community, finding some service in the community that might help the individual. And what I can bring is, again, not as good as a social worker, but I bring a rudimentary understanding of what's out there in New York City that for someone who is older. And oftentimes this is access to services or to programs that people knew nothing about. There are other things that we talk about. Pain has come up not infrequently. Gait disorders, obviously. Goals of care and overall health have also come up. So we offer some of the necessary care. We can uncover problems. We can confirm suspicions. We can introduce new resources. We can help establish or reset priorities. Again, we nibble at the edges with medications. I haven't figured out how to deal with polypharmacy. It's a great goal of mine, but I don't know what to do about it. We're documenting it well, though. It remains a huge challenge. The question, though, that I want to leave you with is how are we going to combine the components of care? And you know, to walk into an HIV practice, one sees that there is an ongoing collaboration between the subspecialty care and the HIV care. I've not seen difficulty in say, coordinating care, at least with our groups and between the subspecialists and the HIV specialists. The question is, what then does geriatric care do? And I've created this and in terms of silos because I truly believe that's what we're dealing with. Again, I think we are working directly with the HIV providers, and we are modifying or asking them to think about how they want to interact with the subspecialists. The problem is this is too medical, and to me the way this the program works is by recognizing that social services, both from the geriatric end and the HIV end, are critical to the care and well-being of our patients. They have been traditionally entirely separate, and I consider it one of our goals to either combine those silos or figure out how to get those silos to talk to each other. So how are we going to integrate care? And this is why being a geriatrician in an HIV practice is very humbling, because what I can do is very, very small. When I see the world around me and my patients' worlds, I'm struggling with figuring out how to get them what they need. Because we're basically doubling the size of the system that they need and that they need access to and that we need to learn about. So are we merging the silos, or are we trying to create seamless access? How are we being reimbursed? And how flexible can we be? And this goes back to the UCSF data. The program that helps the people who are going to learn to age with HIV is going to be very different from the program that is more classically geriatric and is helping people with significant functional and cognitive impairment. And how flexible can we be to manage both of those things and offer the services for both of those things? Or do we need separate programs? And these are the things that we're struggling with, and I'm hoping we can have some discussion about. So I will end there. Thank you.